Welcome. Welcome to the Water Talks. Water Talks is a series of presentations on hydration, around hydration. And today I have the pleasure to introduce Dr. Brenda Davy, who's a professor in the Department of Human Nutrition, Food and Exercise at Virginia Tech, and the director of the Laboratory for Eating Behaviors and Weight Management. She conducts research in investigating the role of diet and physical activity behaviors in prevention and treatment of obesity and related conditions. Dr. Davy is also a fellow of the American College of Sports Medicine and the Obesity Society, and she serves on the board of editors for the Journal of the Academy of Nutrition and Dietetics. So we're very, very excited to have you here. We look forward to your talk. Before we start, couple things. If you have any questions, please use the Q&A and we'll address the questions at the end. Also, a quick reminder, the next water talk is coming up on September the 24th by Dr. Robert Salis, Wednesday again, 10 a.m. Pacific time, 1 p.m. Eastern Standard Time. And without any further ado, Dr. Davy, thank you for accepting the invitation, and we're looking forward to your presentation.
Are my slides visible?
Yes, yes.
Okay, perfect. All right, well, thank you so much for the invitation to speak to your group and to the audience about a topic that is near and dear to my heart, water intake and hydration and weight management. And what I'm going to talk about today, a little bit of background information, and then dig into what the evidence base is surrounding the question of water intake and weight control. Okay, so it looks like, there we go. So I'll cover a couple of different areas. First, the health benefits of water consumption, probably a lot of things that are well known to this audience, but maybe a few benefits that are less well known. I'll talk about water consumption practices, recommendations, and barriers to water consumption. And I think that is relevant to this topic because if you're a health practitioner or an athletic trainer working with athletes or individuals or clients, it's important to understand what our current habits are related to water consumption, what the recommendations are, but also some of the reasons why folks may not meet water intake recommendations so that you can address those then with your clients or patients. I'll talk about water and weight control and that evidence base, and then conclude with a few practical strategies for how folks might increase their water consumption. So first, the health benefits of water consumption. Water is considered an essential nutrient. And so we do have a dietary reference intake for water, like we do with micronutrients like calcium and iron. And it's important that we consume adequate amounts of water that allows us to maintain water balance, because we experience losses through our sweat, our urine, our feces, and also our breath. Water is a main constituent of our body weight, so representing maybe 60% of our total weight. And some of the critical functions that are needed with water in our bodies are thermoregulation, the transport of oxygen and nutrients, and then also waste removal. But it's also very important for maintaining good kidney health, genitourinary health, and also gastrointestinal function. So maybe a lesser well-known benefit of water consumption, an analysis that was recently done using NHANES, which is a nationally representative population data set in the United States, found that among adults in the US aged 45 years and older, plain water intake, so tap or bottled water, was inversely associated with risk of gum disease, such that individuals in the highest quartile of water intake had a reduced risk of about 22% for periodontal disease. Also related to kidney stones and urinary tract infections, there have been randomized controlled trials that have demonstrated reductions in risk of kidney stone formation with the addition of 2 liters of water intake per day, and also decreased frequency of urinary tract infections with an increased intake of 1.5 liters per day above what individuals were currently doing in those studies. And then also a substantial amount of research on weight control and obesity that I'll talk more about later. So some other potential benefits that were reviewed in this really nice, recently published systematic review. It was very concise and very easy to read. So if you're interested in this topic area, I would certainly take a look at it, showing that there are RCTs that also support benefits of increased water consumption for migraine prevention, for improvements in fasting blood glucose concentrations and glycemic control, for chronic kidney disease, and also for hypotension. So dehydration is an important reason for consuming adequate water intake, and research using objective indicators of hydration status, such as serum or urine osmolality and osmolarity and urinary specific gravity, have indicated that dehydration is pretty common in adults, representing about maybe 40% of adults. Individuals with obesity have this even higher prevalence of dehydration, closer to 50%, and that's even higher in middle-aged and older adults. And even mild levels of dehydration, so losses of 1 to 2% of body weight, can adversely impact cognitive or brain function, physical and athletic performance, and also perceptions of mood and fatigue. So how do we do in terms of meeting the recommendations? These are some older NHANES data, but still relevant. And what you can see on the slide, on the bar graph on the right side of the slide, shows intake in men and women in the United States across different age ranges. And what you can see with the dotted line representing what's considered our adequate intake of water, according to the dietary reference intake, of about 3.7 liters in men and about 2.7 liters for women, you can see that we do pretty well when it comes to total daily fluid intake meeting the recommendations, with women doing a little bit better than men. But what may stand out to you is that individuals in that last bar are age 60 and older, and both men and women in that age range seem to be particularly at risk for inadequate fluid intake. So we may do a fairly good job of meeting our total fluid intake with the exception of adults. Analysis in 2020 also using NHANES probed a little bit more into intake habits and trends in the US. And what this investigation revealed was that we get our drinking water from a variety of different sources, 60% from tap water and about 40% from bottled water. And that analysis indicated that about 40% of US adults and children met current water intake recommendations. They also did an analysis of beverage intake habits over time and found that in recent years, sugary beverage intake has decreased and plain water intake has increased. So there is I think, growing recognition of the importance for consuming adequate amounts of water. This is a table from that article that provided a little more information on exactly where our fluid intake comes from. And so in this analysis, about 1 liter a day of drinking water was consumed, so about 1,000 milliliters or 4 cups. With an additional 1,000 milliliters coming from other beverage sources. And those included things like hot tea and coffee, sodas, milk, and sports drinks. So the individuals who may be most at risk for not meeting our fluid intake recommendations are older adults, and that was recognized in our current edition of the U.S. Dietary Guidelines for Americans. Individuals who are Black, of lower educational levels, in low income groups, those who have lower leisure time physical activity or who smoke, and also individuals who receive SNAP or WIC benefits. So what are some of the barriers to consuming adequate drinking water? First, a lack of awareness of the health benefits or importance of water, but also concerns over tap water safety. And that's been, I think, very important in the past 10 or 15 years as we have highly publicized events of water quality problems, contamination, et cetera. So concerns over tap water safety are a big issue. Also, taste preferences and aesthetics. Individuals vary in their taste perceptions, and some individuals are very sensitive to odors that might be in water or tastes of things like chlorine in water, and it may be sort of aversive to them. Forgetting and lack of thirst can be an issue, and then also lack of access to drinking water. This is an issue in our region of the country. A lot of individuals are on well systems, and a lot of individuals in rural regions in this part of the US also rely a lot on roadside springs as their source of water. And wells and natural springs are perceived as being healthy sources of water and safe sources of water. However, there are some serious concerns about the safety of those. And we have researchers here at Virginia Tech who study this issue and have indicated that it can be problematic for folks who are not on public water systems. An example of some of the consequences of concerns about tap water safety are highlighted in an in-press article in Journal of the Academy of Nutrition and Dietetics. If folks have concerns about their safety, their tap water safety, they may tend to rely on bottled water. They may consume fewer fruits and vegetables, perhaps out of concern for washing them and the safety of their tap water. And so it's possible that tap water safety could be linked to consuming healthier foods, at least some types of healthier foods. For folks who do have concerns about their tap water safety, the EPA has a searchable website of the results from local water quality testing that you can direct your clients or patients to. It's required that water testing happens annually by public water utilities. And you can find your local water quality data through this website on the EPA site. You can hover over your state and enter your zip code, and it will provide you with those data. One of the challenges with using this data is that it is not very readable and understandable to consumers, and it may end up just worsening distrust because of confusion over whether the results indicate the water is safe or not. And so there are plans for efforts to improve these, the readability of these reports called consumer confidence reports by 2027. Regarding taste preferences and aesthetics, there are a few suggestions for folks who have those types of concerns. Water filters can remove some of the factors responsible for the tastes or odors that folks may detect. Flavorings can be added, like fruit slices or lemon and cucumber slices. There are a variety of commercial flavoring packets that can be added to water so that folks may like the taste better. And though bottled water is an option, there are concerns about the high cost and also about impacts on the environment. So getting to really the meat of what I want to present to you today, the topic of water and weight control and the state of the evidence in that area. We now have two recent have evaluated randomized control trials and determined that the replacement of sugary beverages or other calorie-containing beverages with analysis that just included studies that were 6 months in duration or longer and found a significant BMI reduction in children and adults using water or non-nutritively sweetened beverages as a replacement strategy for sugar sweetened beverages. And so the magnitude of that reduction was about 0.5 to 1 kilogram. A second RCT that didn't have that restriction on study duration found a pretty similar magnitude of effect of benefit, and they focused specifically on water consumption as the replacement strategy. So it may be that replacing sugary beverages with water is one way that may help folks better manage their weight. It's also possible that consuming water may reduce appetite sensations and promote increased sensations of fullness, which might help folks better manage their body weight. We've done some work in this area, and I'll provide some details on that in a moment. There's also some evidence from some older studies that were done in Europe of this water-induced thermogenesis, or the increase in metabolic rate that might occur when folks drink water. And that's thought to potentially be due to changing the temperature of the water to meet body temperature. The magnitude of this effect is really small, like maybe 20 or 30 calories when that happens. And so it's not likely to be a major factor or a major mechanism by which water could help with weight control. We do have a little bit of data on improvements in physical activity level with increasing water consumption. And so that's a possibility that could occur through less feeling of fatigue or feeling of a greater energy level and better capability to engage in physical activity. There is also a little bit of data that might support increasing water intake as supporting cognitive or executive function. So improved brain function that may better facilitate decision-making about food or beverage choices. So we have a great deal of observational research that supports the benefits of water consumption for weight control. And I'm just going to highlight two investigations that both used, or at least this first one used, objective indicators of hydration status. So urine osmolality was the measure used. And what this analysis in NHANES, so adults in the US, found were that adults who were inadequately hydrated had a 60% greater risk of obesity compared to adults who are adequately hydrated. And then another analysis in a large sample of US adults found that over a 4-year period of time, that each 1 cup per day increment of water intake was associated with 0.13 kilograms less weight gain over 4 years. That doesn't sound like a very large magnitude of an effect, but if you consider that's just 1 cup per day increment, then maybe increasing water intake 4, 5, or 6 cups a day would have 0.13 times 4, 5, 6 results in improving reduced weight gain over a 4-year period of time. So there are some experimental research studies that have used laboratory-based test meal studies to evaluate the acute effects of water or other beverages on food intake. And this work I'd like to highlight is work done in the laboratory of Dr. Barbara Rolls at Penn State. And the background idea here is that solid forms of food are more satiating than liquid forms of food. So, for example, Dr. Rolls did studies that compared different forms of apples and how those affected appetite. And there was this sort of hierarchical benefit on feelings of fullness, such that the most solid form of the food, an apple, was more satiating than applesauce, apple juice with fiber, or plain apple juice. So apple juice was the least satiating of those. And then another study that I would like to highlight from Dr. Roll's lab was this one. And what they did in this study was they brought folks into the laboratory for test meals, and presented them with a variety of different beverages in a randomly assigned order. So they tested a bunch of different beverages: water, diet soda, regular cola, juice, and milk, and compared that to a no beverage condition. And what they found was that in the conditions where calorie containing beverages were provided, meal calorie intake was additive to the beverage calorie intake, which resulted in a total meal calorie intake that was higher. And so you can see that in this bar graph on the right, that the cola, juice, and milk conditions had a higher meal energy intake compared to water or diet soda, the calorie-free beverage conditions, and then also the no beverage conditions. So what we can conclude from that is that the consumption of calorie-containing beverages with a meal is additive to meal calorie intake. So this led us to pursue some studies in our laboratory using this test meal type of approach. And what we were interested is using this preloading paradigm that Dr. Rolls has studied, using soups or salads prior to meals to determine what impact that had on meal calorie intake. What we did was use water as a preload. So think about it as like a water appetizer. And what we did was have folks consume 500 milliliters, or about 2 cups of water. And then we had them wait 20 or 30 minutes. And then we presented them with a tray of food that had about 1,000 calories or so worth of food on it. So we would sort of call that an ad lib buffet meal, or an ad lib test meal. And without them being aware of what we were doing, we measured what they ate and how many calories they ate in response to this water preload. And we compared that to a condition where we had them come in and did not give them that water preload. We just had them sit for 20, 30 minutes and then gave them the test meal. And what we found was that in young adults, so individuals aged 20 to 35, we found that it did not matter whether we gave them water or no preload. They ate about the same amount in that test meal. So it was about 900 calories of food from the test meal. In contrast, we found that our older adults, so they were 60 to 80 years of age, we found that after the water preload, the older adults reduced their meal calorie intake by about 90 calories. And what we did to make sure that this was something that we could replicate, we repeated this study in individuals who were middle-aged and older, but had overweight or obesity. And we found a very similar magnitude of effect of about 75 calories using the same study approach. So that gave us some confidence that, in fact, you can reduce meal energy intake with this water preload in older adults. So that led us to obtain funding for a small randomized control trial. We enrolled 48 adults who were 55 to 75, who had either overweight or obesity. And we gave them instructions to consume 2 cups of water prior to each main meal, so breakfast, lunch, and dinner, 3 times a day. and compared that to a group that was given the same diet instructions minus any information or guidance on water intake. All individuals were provided with dietary counseling and provided with meal plans and weekly follow-ups to support their adherence to the diet. So the only thing that differed between the two conditions was the pre-meal water instructions. And what we found was that over a 12-week period of time in this weight loss study was that the individuals who were given instructions to consume water 3 times a day lost about 2 kilograms more weight in 12 weeks, so about 5 more pounds. We then continued that same study for a full year to evaluate whether or not that weight loss was maintained with this pre-meal water intake strategy. So over a full year, we followed those individuals and continued to provide them dietary counseling, but did it on a monthly basis. We gave them pedometers and tracking logs so that they could monitor their water consumption, their step counts, and their body weight. And again, we had that same control group who was given all of the same instructions for self-monitoring and tracking, without the water intake instructions. And we did find that the water intake group did better, such that they actually lost more weight in the first 6 months of the maintenance phase of the study, and were still a half a kilogram below that baseline reduced weight after the weight loss phase, whereas the non-water group gained about 1 kilogram over the year. What we found also was that the water group was more adherent to our step count instructions and tracking. They were advised to aim for about 10,000 steps per day, and we found that they were more likely to achieve that goal compared to individuals in the other group. So they were more physically active. So following these studies, we were trying to figure out if we wanted to pursue a larger scale NIH-funded trial to test this in a larger sample of individuals. We were trying to figure out what other mechanisms might be coming into play here that we could incorporate into a large-scale trial. And so I was fortunate to have a collaborator who's a cognitive psychologist here at Virginia Tech, Dr. Ben Katz. And what we did at that time was conduct a systematic review to learn more about the state of the literature related to hydration status and executive function. And executive function refers to things like your working memory or your attention or inhibitory control, which might relate to your ability to restrain yourself from behaviors that might not support weight management and make better choices, like, for example, choosing a healthier diet. What we found was that about half of the studies found adverse effects of dehydration on executive function. But the evidence seemed to be more consistent when looking at rehydration or adequate hydration studies. That there were benefits on executive functioning when folks were consuming adequate amounts of water intake. And then we came across some research that supported baseline executive functioning as supporting weight loss and increasing success of folks achieving a 5 to 10% weight loss in an intervention trial. And so this gave us some preliminary ideas, at least, for including a study of executive function in our work. And so that leads me to the trial that we were eventually successful in obtaining funding for. We are in the midst of a 5-year randomized controlled trial focused on water intake and weight control in middle-aged and older adults. So we're in year 3 right now. And I just want to acknowledge my collaborators who worked with me over the years to get this preliminary data, as well as finally secure funding for this grant. Doctors Ben Katz, Kevin Davy, and Dr. Tina Savla here at Virginia Tech. On the left, I want to acknowledge some of my research team members, those who are around the lab last week when I was running around trying to get some pictures. Dr. Kristen Howard, who's our project director and also a nurse practitioner. Teresa Libera, who's a biomedical engineering student working with me. Elena Lascaradou, who is a postdoc working on the project. Shahed Sanuri, who is a master's student working with me, and then a whole variety of individuals who were not around, who are contributing in really important ways to our study listed there. One of the benefits of having a large trial funded like this is that it provides really excellent training opportunities for students and also supports a lot of master's and PhD projects. So I'm really lucky to have a great group supporting this project. So this is the conceptual model that we use to sort of think through how we wanted to design the study and evaluate potential mechanisms that might explain why water intake is helpful for weight control. And so we've ended up with a 3-group randomized control trial. So we have a control condition that's not pictured here. But our ideas were to have 2 other water groups in the study. We wanted to have this pre-meal water group consistent with our original preliminary study that would be advised to consume pre-meal water 3 times a day, as well as follow a low-calorie diet and receive counseling for that. And our idea was that that approach would improve hydration status, which would support better cognitive functioning or decision making around diet and physical activity behaviors, but it might also reduce feelings of hunger and increase fullness, which would help folks better adhere to the low-calorie diet. And that those 2 mechanisms would support this group as being most effective for weight loss and maintenance. But we also have this other water group who would consume the same total volume of water per day, so 1,500 milliliters per day or 1.5 liters. And we thought that with that group, we would still see improved hydration status and benefits on cognitive function that would also support weight loss and maintenance, but maybe not as effectively as the pre-meal water group. So here is what our inclusion criteria are for this trial. We are recruiting individuals aged 50 years and up. This is a change from our original trial. We decided we did not want to have an upper age limit. There didn't seem to be a good reason to have that. And so if folks were age 50 and up and had overweight or obesity, we wanted to have them participate in our trial. We are recruiting folks with a body mass index at or above 25, so meeting overweight or obesity criteria. And we don't have an upper BMI limit, which is also a change from our original trial. And that was also an important change that we thought would help us be more inclusive and include more individuals with a wider range of BMI who could benefit from participating. Individuals need to be weight stable and willing to complete the study protocol. We are excluding folks who have a high usual water intake, so above 1,500 milliliters a day. And I have to thank an anonymous reviewer of the grant for bringing this idea to our attention. In the original trials, we did not exclude individuals based on their usual water consumption habits. But what this change did is it allowed us to really focus on folks who might most benefit from increasing their water intake, those who are most at risk for dehydration. We exclude individuals who have uncontrolled hypertension or diabetes, those who have medical conditions that might warrant a special diet or a fluid restriction, anything that might preclude participating in a physical activity program, walking, which is what our the physical activity component addresses, and also those who are taking anti-obesity medications. So this is an overview of what we are doing with this trial. So consistent with the original weight loss and maintenance trial, we have a 12-week weight loss phase and a 12-month weight loss maintenance phase. Dietary counseling is provided weekly during weight loss and monthly during weight loss maintenance. And we have a lot of different testing that we do at various time points throughout the study, and that's shown here. We are evaluating blood pressure and body composition. We are taking blood, we are taking 24-hour urine samples, and we are conducting 2 different in-lab test meals. The first in-lab test meal is calorie and macronutrient restricted. With that, we are interested in changes in appetite hormones that could occur in response to increasing water intake compared to no water intake. And then the second test meal, we are evaluating ad lib food intake, as we did in those early studies where we provided the buffet meal and studied how much folks ate in response to increasing their pre-meal water intake, so 2 cups right before the meal, compared to not having any water before the meal. And so we make those measurements again at various time points throughout the study. We are also doing a lot of dietary recalls so we can monitor what individuals are consuming and how their diet may change over the course of the study, and doing a variety of surveys. And then lastly, we're tracking urinary tract infection and kidney stone occurrence. These are both really common conditions in middle-aged and older adults, and they're even more common among older adults with obesity. And so we're evaluating whether or not there are any benefits that we can detect with those outcomes. And here's where we are at right now. As of August 5th, we had screened 209 individuals and enrolled 194. And we've had 126 complete the weight loss phase and 15 complete the full 15-month trial. So we're making pretty good progress. We've recruited individuals with an average age of about 62 and an average BMI in the obesity range. Mostly female and mostly white, and this is common in weight loss trials, but we are taking steps to try and improve our recruitment of males and individuals of racial or ethnic minorities. Okay, and I would just like to conclude with a little bit of some practical strategies for increasing water consumption. I've already addressed taste and acceptability and concerns about water safety, but monitoring fluid intake adequacy is something that we are doing in our study, tracking water intake habits. And that's an effective behavior change tool that could also be applied to folks who feel like they want to increase their water intake. So monitoring using maybe apps, smart water bottles, using things like urine color charts, which are a really simple indicator of hydration status, etc. For individuals who forget or are not feeling thirsty, this is a common problem with individuals as they age. Your sort of natural thirst sensations tend to decline. That's why older adults may be more susceptible to dehydration. Again, apps and smart water bottles, or carrying a refillable water bottle, or using strategies like having a glass of water before your meal or with a meal. And then before, during, or after exercise, and then of course as thirst increases. And some behaviors change strategies suggested by the American Heart Association, using this sort of cue, routine, reward approach, establishing intake goals, or integrating water intake into a daily routine. And one of the, I think, benefits of water consumption as a health behavior is that it's possible this may be a simpler strategy for folks to change compared to things like making big changes in your dietary intake or changes in your physical activity level. It may be simpler and more achievable. And it's low cost if folks are using tap water, if they have access to it. And they may experience some benefits, especially things like the cognitive benefits or mood benefits quickly. Probably folks have seen these, but they are useful for quick tests of water intake adequacy. They could be used in school children or in athletes or in older adults in a variety of settings, just aiming for urine that's in this very pale, light lemonade color range probably indicates that for most folks, they're doing okay with their water intake adequacy. And with that, I will conclude, and I'm happy to take questions. And if folks are interested in some of the details and references that I mentioned during this presentation, we've recently published an overview that's really similar to what I presented to you today in physiology and behavior. So there's a link to that article.
Thank you so much, Dr. Davy. It was a really, really insightful presentation, and I know this is a topic that a lot of people are very interested. We have a couple of questions already, so I will start with the first one. The first question refers to the difference between the dietary guidelines in Europe versus the United States, which is in US is about for adults, females and males is 2.7, 3.7 liters per day. In Europe, it's 2 liters to 2.5 liters. So there is about a liter difference. So any comments on this? Do you think the European are too low? Why there is this difference? Lots of questions. There is a whole paragraph about this.
Right. What might explain that? So our water intake recommendations, which are actually our fluid intake recommendations, it's not specifically water. They are based on an adequate intake. So what is the level of intake that appears to be adequate for the US population? We don't have enough evidence from other types of studies to form an RDA. You need a lot more research to be able to develop those recommendations. And so what we use instead for the DRI is this adequate intake. And that's just based on what appears to be adequate based on our population's intake habits. So that's where the US adequate intake comes from, or our water intake recommendations. So that's maybe one reason why there's a discrepancy between what's recommended in the US versus other countries, is because ours are based on the US population. One of the other reasons why it's difficult to make a more evidence-based water intake recommendation for our population is because it varies so much with the climate that folks live in, with body size, with physical activity level. So there are a lot of factors that play into an individual's water requirements. And so it's really difficult to come up with a good recommendation for that reason too.
Thank you. I can move on to the next question, which is people are asking whether people, when they're doing the preload, like one of the trials that you have run where you give 500 ml before the meal, do people get used to it? Do they get adapted, acclimated in this effect? And whether you have any experience or any, or like, I don't know, any thoughts on that topic?
Right. So what I can tell you based on that, in our original water trial, we did this same acute test meal with the water preload at baseline and then at the end of the 12-week weight loss intervention. And we found that only at baseline did the pre-meal water significantly reduce meal energy intake. What we think may have happened, though, is that after weight loss, after the 12 weeks of the trial, their individual requirements were lower. They had lost weight. Their body size was smaller. And so it may have just been that we couldn't detect a significant reduction in calorie intake because of their energy needs being less and them eating less as a result of that. We may not have had enough power to do that. So we're not sure, I guess in response to the question, we're not sure if there's an adaptation or not, but we did detect a significant difference at baseline and not at 12 weeks. So it's possible that could happen as well. So maybe this larger trial will give us more information on that.
Okay, we have lots of questions and they're coming in, so I'll do my best trying to cover as many as possible. Any thoughts about carbonated water versus plain water?
Yeah, I get that question. And we didn't test that, and so I don't really know. But what I can think of is that, if you consider the acute test meal studies that were done in Barbara Roll's lab, where she compared, she had all of those different beverages, and that included a diet soda as well as a regular soda, and I would assume both were carbonated. And they were still able to detect a greater total meal energy intake with the regular soda, and a lower energy intake with the diet soda. So I'm not certain about the carbonation effect, but it seems like you still get a benefit in reducing calories using a diet soda compared to a regular soda.
Thank you. A question on the over intake and potential, in parentheses, hyponatremia of water. There is a short statement that I would prefer to read it versus trying to describe it myself. I believe too much water can overwhelm the kidneys, electrolyte imbalance, and swelling. We are known to be indulgent. Do you worry about people drinking too much?
Right. So that's a very important issue. There are instances of hyponatremia and overhydration. Your kidneys are limited in their ability to excrete water. They do a pretty good job managing that to prevent this from happening. But with large volumes of water, that can happen. It can be more than the kidneys can excrete in a given amount of time. That is the main potential adverse event that we are monitoring for in our study. And so we collect 24-hour urine samples, we evaluate urinary sodium and blood sodium so that we can monitor for that. We have not had we may have had one or two concerns and then did repeat values, and then it ended up not being a concern. It has not been an issue in our study that has led to any changes in what we're doing, but it is something that could happen, so we are monitoring for that.
All right, thank you. In your opinion, could there be potential benefit from recommending additional water intake to athletes who are aiming to weight loss?
So in other words, could increasing water intake benefit athletes who are concerned about weight control, who maybe for performance reasons need to be careful about weight? So I think that there could be a benefit there. It would not, depending upon the age of the athlete, it may not be a benefit of increasing fullness and reducing meal calorie intake, like what we're studying now with pre-meal water. But what could happen is that if folks are being recommended to increase their water intake without realizing it, they may reduce their intake of calorie-containing beverages. And we did see that in our original weight loss trial, that individuals did seem to be substituting water for some of the other calorie-containing things they were consuming. So there could be a benefit if the athlete is consuming a lot of calorie-containing drinks, maybe energy drinks, maybe a lot of sports drinks. So it could potentially be a benefit.
Awesome. We have a few more minutes. If you don't mind, can I go on?
Sure, no problem at all.
Is there any correlation between mental health and adequate or increased water intake?
That is a good question. And honestly, what comes to mind are the studies that were done by folks in Dr. Armstrong's lab. And I remember a variety of mood types of assessments, feelings of fatigue, et cetera. There was a whole host of assessments that were done in those studies, and there were some benefits that were detected in some aspects of either mood or mental functioning. And I can't recall specifically what those were, but I think there is some support for that.
Okay, thank you. Actually, Dr. Armstrong is in the audience.
Oh,
I won't ask him to answer the question, but he has a question for you, which I'd
okay.
like to read. Thank you for your thorough presentation. Very interesting. Please comment on the inclusion or non-inclusion of water in the U.S. My plate.
I'm sorry, repeat that again.
In a comment on the non-including water in my plate. The my plate
Oh, in my
recommendation
plate.
and the
Okay.
USDA recommendation. Yeah.
So that has been a topic of discussion for several years with folks responsible for developing the MyPlate recommendations. And in fact, there have been discussions with politicians to support this idea in past efforts to update the MyPlate recommendations. And so one of the suggestions was that in addition to a glass of milk being present in the graphic, a glass of water also be present there. And that has not happened yet. I can't speak as to why. But yet, even in the dietary guidelines written document, there are recommendations to maintain hydration for certain populations, like older adults in particular. So I would certainly support including that in my plate, and hopefully that will happen at some point in the future.
Great, thank you. Um, Assuming that drinking the same volume of plain water with meal versus on an empty stomach, it reduces urinary output and improves fluid retention. How does this affect hydration-related health outcomes?
Okay, that's a really good question. And what comes to mind is the research done by Dr. Maughan, who developed sort of a beverage hydration index that evaluated the hydrating potential of a variety of different beverages. And I believe he found there was sort of this hierarchy of different beverages being hydrating based upon a urinary excretion of fluid, as compared to other beverages. And I can't recall the details on top of that. So that's all I can comment on related to that, but I'd refer the audience member to that really nice paper.
We have a few more questions. Does black coffee count as water for calculation purposes?
It certainly does count as part of an individual's total fluid requirements. And there's this concern about some beverages like coffee or tea being dehydrating because of the increased water excretion that might happen, a diuretic effect with consuming those. But when this has been examined, this is included in the dietary reference intakes chapter on water intake. When individuals are studied over the period of a day or more, and they're coffee consumers, it does not appear to impact their hydration status negatively. So there might be an acute diuretic effect, but that doesn't seem to persist when you look over the course of a day or so. So it does not seem to be a major concern with coffee being part of total fluid intake.
Okay, great. We have a question on electrolytes, and it seems to be a lot of discussion of hydration on social media and a lot of focus on drinking electrolyte beverages with either added sugar or artificial sweeteners.
Mhm.
Thoughts on this trend or any concerns about it?
So, you know, artificial sweeteners, that's a whole webinar unto itself. There's a lot of controversy, a lot of mixed evidence on whether or not artificial sweeteners are helpful or harmful. It seems for weight management they may be helpful, but there's still a lot of questions there. With regard to electrolytes, I think that we get a lot of electrolytes are present in foods, other things that we eat or drink. And so how much an electrolyte replacement beverage is needed for the average person, I'd be skeptical that it was needed. Where it might be, though, of benefit is if you have individuals who are heavy sweaters or they live in a climate that's very hot and their water losses are very high, or athletes who may be losing a lot of electrolytes through their sweat. So it may be a benefit for those populations. But with respect to weight control, that would be considered a sugary beverage. If it's an electrolyte beverage that has some sort of added sugar to it, then it would have calories in it, and that's in that sugary beverage category, which is something that, as you know, in our dietary guidelines, are recommended as something that we limit consumption of.
Okay. Uh, can I go on to a few more?
Sure.
All right. It's a lot of questions, and they keep like I feel I'm getting to the bottom, and then I get more coming in. So I'll do my
That's a
best
good
to.
thing. I'm glad there's interest.
Should dietitians aim to increase total fluid intake, even though the consumption of sugar-free sport drinks, or exclusively through consumption of plain water? So whether you
Oh,
can have non-sugar containing beverages, or do you have to have plain water?
right, right. So, there are health benefits unique to water consumption. And so I think that's one piece of information that would be used to emphasize water as the main source of fluid in the diet. Um, there would be concerns about having other beverages that might have added sugars to them, because added sugar intake is something that we are advised to limit. And that's particularly important for weight control or for management of other diseases and conditions like type 1 and type 2 diabetes. Um, there is also, though, an issue of individual preference. And I think if someone really does not like the taste of water and has one or two diet beverages, and that allows them to meet their fluid intake needs for the day, I think that's sort of a personal decision that a dietitian and their patient or client could discuss.
Great. We have a question. Actually, there are two questions. I'm trying to combine both of them regardless the temperature. So whether the temperature of a beverage has an impact, and whether the temperature has an impact on the metabolism, and whether there is any mechanism related to energy expenditure.
Right. So what comes to mind with that question would be those studies of water-induced thermogenesis. And so I believe in those studies, they used chilled water to evaluate that, and then concluded that this increase in metabolic rate or increased burning of calories with the chilled water consumption, maybe having that chilled water being adjusted to body temperature was responsible for that increased metabolic rate with water consumption. It was a pretty small effect of an increase in metabolic rate. So that was the one thing that I mentioned about that. Um, as to whether or not the kinds of studies that we're doing, it would matter whether or not it was warmer water or hot water versus chilled water. We don't evaluate that. We've had room temperature or chilled water as what folks are most likely drinking with the studies that we are doing. So I really can't speak to whether or not we would see the same type of benefits if it was pre-meal water that was heated versus not heated. That I'm just not sure about.
Okay, awesome. And we're almost on the top of the hour. Dr. Davy, thank you so much for taking the time to present in the Water Talks. Has been a great, one of the best hours of the month, if not of the year. Uh,
Great.
and thanks all the audience for joining in. Our next talk will be September the 24th, same time, same place. I put the link if you want to register. Thanks again. Bye-bye.